to others. Anyway, I'll just share my screen so it looks a little bit professional and put myself up in the corner. Hi everyone and welcome. It's been a little while since we've done these webinars. So Happy New Year to all of you. Yeah, so Graham came up with this great idea to do the Nordic clinical series, and then I added on 2 practitioners from practitioners, because some of you have already met Graham, and he is one of our practitioners up in Stockholm. He's the head practitioner up there, and he is an amazing practitioner, and he's an amazing teacher as well. So he made up this little plan where we are going to every month pick a topic, one of our tests, and just really cover it, the basics of it, because sometimes we forget the basics. We also sometimes have new practitioners who needs to have the basics, and it's just nice to have see how other people present and get inspiration to how we can present ourselves and so on. So yeah, that's what all this is about, sharing knowledge, as I normally say. And so this is a plan for the rest of the year. We will have other webinars if there's things that comes up. We will have one on autism mid-February as well. We will send invite out on that. But before I pass on the stage to Graham, then some of you have probably noticed that there's some issues with some of the supplements that we are sending out, and that's because of Brexit. So Brexit happened on the 1st of January, and before the 1st of January, we had opened a warehouse in Holland and sent stock with trucks to Holland. And on the left-hand side, you see our Dutch warehouse, and on the right-hand side, you see our UK warehouse, meaning that everyone in Europe is getting supplements. So you do the order as you normally do. It's paid in pounds, but the supplements are shipped from Holland to people around in the EU. Everywhere else in England and around the world, the rest of the world, is getting shipped supplements from our UK warehouse. There's different rules and laws and regulations, and we are trying to understand it. And there's also a big problem in general with supplements companies that they can't supply that much. So, and because we are, of course, your buddies and partners on this, we get the hits sometimes, but just really be aware that we are doing all we can to supply you. Sometimes it's not because of the EU regulations. Sometimes it's because there's just, the product isn't there at the moment, so they can't supply. So, but we try and reach out and we try and find substitute products. Sometimes there's a different brand that has the same product and so on. So, but we are reaching out, and on top of this, there was also issues with 3D Secure, which is all the payment gateways that expect an extra security layer when you do payments. So that was, and that wasn't even our fault. It was the payment gateways that weren't, it was like they weren't ready for this. So we've had a lot of challenges in January, but yeah, it's working. It's a little slow. We do reach out as much as we can. So please bear with us, but just in your heart know that we are really working hard to help you. And in all this, of course, we want to educate, and that's where Graham comes in today. And today's topic is going to be on SIBO test. And I will just stop the sharing here and stop it. And then Graham will take over the talk now. What will happen when Graham is talking is that I will be the moderator on the side, so you can ask questions. I'll put them down on the side, and then at the end of his talk, we have some time for Q&As. So yeah, I'm excited to listen.
Great, thanks, Anne-Catherine. I'll okay, I've just let there's still some coming in, so
I'll handle those now.
You can handle those. Yeah. Right, let me just share my screen here. Okay, let's move this around a little bit. Okay. see this okay? Working, Anne-Catherine?
Yeah.
Great. Okay, so yeah, welcome everyone. And of course, today I'm going to be talking a little on SIBO testing. So the idea behind this is just to give everyone a bit more confidence in basic test reading and understanding where which test or substrate is most appropriate, why you might do SIBO testing, for example. So yeah, today, why is SIBO testing helpful and under what circumstances? Use glucose or lactulose, some basic result interpretation, and then some treatment strategy options and case study examples. And then hopefully by the end, we might have some time left for some Q&As. Just if you don't know me, well, now I spend most of, well, all of my time with the Nordic group. So some in regards to education like this, helping with Nordic laboratories. Most of my time is spent here in the clinic in Stockholm, where I help oversee and run the medical and non-medical team here. We're doing research in functional medicine, so I'm involved with Karolinska, working on IBS and chronic IBS cases and where functional medicine can help. And also we have research going on at the clinic in regards to our functional medicine protocols. So that's really exciting, and every day I get to work with a fantastic team of everything from endocrinologists to health coaches and nutritionists, and we all try and basically work together for the best outcome of the patient. But over the last 15 years, I've worked in different areas of health and medicine for Nuffield hospitals in the UK, London General Practice and the Bosco Clinic in the Harley Street district. So really trying to combine different areas of knowledge and expertise, both in obviously allopathic medicine and areas like alternative, and then of course I've really tried to bring all that together in my functional medicine model. So today we're talking about SIBO, which of course stands for small intestinal bacterial overgrowth. And really all that SIBO is, as we can see in this picture here that I have up, is where bacteria from the colon essentially moves up and populates the small intestine. So it's just more about SIBO being a condition where bacteria is in the wrong place at too high amounts. And it's actually, when there's been research done into the types of bacteria, these are different strains. So it's not necessarily one strain of bacteria causing the problem. It can be multiple different strains, but essentially it's bacteria living at too high amounts in the small intestine. And of course, many of our patients, or ourselves as practitioners, many of us do also have SIBO, and we can often feel that because we might eat a meal, that meal moves into the small intestine, and then we start to get things like bloating and then gas. So there are many comorbidities associated with SIBO. I've just listed some of these here. If you have patients that have any of these conditions, it may well worth be running a SIBO test to help them along their health journey. And then with SIBO development, so it's rarely just one thing, and it can be a combination of factors. You might get a slow course of SIBO development, which can be things just like a sedentary lifestyle. It can be alcohol. It can be proton pump inhibitors, which of course are widely prescribed for things like reflux. Poor circadian rhythm, stress, or anatomical dysfunction. And then also there can be rapid courses to SIBO development, food poisoning, nerve damage, acute onset thyroid problems, infections, autoimmunity, gastritis in that case. So these are all things, when I'm looking at patient symptoms. Often before we get a patient into the clinic, we have a nice long questionnaire that we can see what's going on, and I'm interested in their history and symptom development, especially of course when they're complaining of things like IBS and bloating. I'm going to start to look out for both, if you like, rapid onset problems and slow development, and try and link these things together to explain to the patient why they may have a problem such as SIBO. Now, when to consider running a SIBO test, I've put together some examples here, but these ones on the left-hand side, gas, bloating, constipation, diarrhea, etc., all down here. And then also on the right-hand side, so I'm always very keen with the team here. So if you're not a medical doctor or medically qualified, then these are some things to be very aware of, that if the patient presents or your client presents with these symptoms like persistent diarrhea that's not been previously investigated, if they have abdominal pain, rectal bleeding, dark stools, blood, extreme weight loss, fatigue, especially fever, reduced appetite, then always cover your back and refer that patient also back to their doctor for further investigation, because worst case here, you don't want to be doing a SIBO test on a patient that has a much more serious condition and needs more acute help and diagnostics. So always ask about patient history. Have they seen a doctor or gastroenterologist? What's gone on? And really, it's very nice when we get patients who have chronic IBS that have been thoroughly investigated for red flags. Then it's easier to just push on with something like a SIBO test. Of course, a common question I get asked is, well, what do you recommend if someone has bloating? And it's a difficult question, because it could be SIBO, but it could be a lack of pancreatic enzymes or low elastase. It could be an infection such as parasitic or fungal. It could be a thyroid problem, to name a few. And it possibly could even be a combination of all of those. So it's not necessarily super straightforward or easy to say, yeah, we do a SIBO test right away. So it is difficult, but ultimately I think that if you're not sure what test to run, any test is better than no test, as it can help to rule things out. I mean, of course, it depends on the patient symptoms and what you as the practitioner want to know. It does depend on the budget of the patient, and it depends on how good the patient will be at collecting the sample. For example, it might not be easy performing a SIBO test on a young child. And then, of course, we need to remember that no test is perfect. There's pros and cons to each test. Yeah, we need to explain that to patients and say there are limitations of what we can understand. And it's important that tests are completed as closely as possible to the instructions. So one thing that I do is I'll run a SIBO test over stool analysis, for example, when there are symptoms like postprandial bloating, so bloating directly after eating, or bloating that increases over the day. So I always like to think that, or definitely see a correlation, those patients that say they wake up with no symptoms and then they start eating and gradually over the day the bloating increases, then usually I would prefer to pick a SIBO test over some kind of stool analysis. But of course, GI symptoms could be coming from either the small or large intestine or both. And of course, if the patient or client has the money, wants to get to answers more quickly, has been dealing with this a long time and is prepared to, going for both tests, then I often like to run both a SIBO and a stool analysis at the same time. to rule as many things out as possible. But I think if you're going to, if you have to pick one over the other, these are the general symptoms where I will pick a SIBO test over a stool analysis. So postprandial bloating that increases over the day, gas symptoms, and they feel better when they do not eat. And then gas or bloating in particular that improves with a low FODMAP diet. And also, I mean, things like if they've had antibiotic treatment and their symptoms improve greatly. So some patients might take antibiotics for a different reason and they notice, oh yeah, my IBS symptoms got a lot better. Then I think that's also a good indication to run a SIBO test. Which substrate? Now at the clinic and the team here in Stockholm, 99% of the time we're usually running a lactulose substrate. So it's not very common when we use glucose. There's pros and cons to each, which I've listed here. So again, no test is perfect. In an ideal world, we probably would run for sure both substrates, but of course, many patients, they're not going to pay to run two different substrates in a SIBO test. So we go with one, and we tend to, as a whole in Nordic group, mostly go with lactulose as the main choice. Now, the risk is that, well, not every bacteria ferments lactulose equally, so we can have risk for a false negative. We can get false positives because lactulose also has a laxative type effect, and it can increase the transit time, decrease the transit time, so it moves faster through the intestine, and therefore we're seeing a positive result that's actually, we're just seeing, the large intestine. The main thing not to run a lactulose test is if your patient has some kind of severe lactose intolerance, because there is a small amount of that within the solution. So if there's intolerance or allergy, then I would always go for a glucose over a lactulose test. So that's really, this kind of maybe 1% of cases, there's some real serious sensitivity, intolerance or allergy, and that's where we're going for glucose over for lactulose. Now with glucose, I mean, the main problem is that glucose is of course rapidly absorbed in the proximal part of the small intestine, so therefore we risk the substrate not making its way all the way along the small intestine, so you might miss a more distal infection. So just some things to think about there, but our general advice is try and go for a lactulose over glucose in most cases, unless there's some kind of allergy or sensitivity. Now, what we do here is when we get the result back, the first thing that I'm looking at is I'm going to this sample normalization area on the right-hand side. And if any boxes are in red at this point, it tells you that that part of the test has not been done correctly. And in most cases, what happens is that patients breathe too, if you like, they do too hard a breath into the device. And that puts too much carbon dioxide in the sample. So it's really important to explain to your patient or client that they must just breathe out normally and not breathe too hard, because that will affect this sample normalization, and it means that we can't take that value into consideration. Now, if there's maybe one or two of these in the test, it's not necessarily a big deal. But of course, if they're doing it for many, then it's going to affect your ability and the laboratory's ability to, of course, interpret that result. So what we're looking at here is we have the gas value on the side and we have time across the bottom. And of course, we have hydrogen, methane, and combined gas values here. And this is a really kind of textbook negative, exactly what we ideally would want to see. So the patient has done a baseline test without drinking the solution, and then has drank the solution, and then every 20 minutes here has done or completed a tube that's filled with their breath sample. So this is how the test works: baseline sample, and then drink the lactulose solution every 20 minutes. We're measuring the gas level, and we can see, of course, here we have the small intestine going up to around the 120-minute mark, and then we're transitioning into the large intestine here. So for a lactulose test, which is not absorbed, so the lactulose is not absorbed into the body, so we would hope that this would be nice and low, and this tells us that there's no bacteria fermenting that lactulose, and then there's no gas then produced and made its way into the test tube. So of course, bacteria ferment the lactulose, that gets absorbed into the body, the gas makes its way to the lungs, and it's expired out into the test. So exactly as we want to see, no gas here, so no bacteria present in the small intestine fermenting the lactulose. And then as the lactulose is making its way into the large intestine here, of course, the gas levels are rising because that's where we have all our billions of bacteria fermenting and using that lactulose substrate. So absolute textbook results here. So as we can see, bacterial overgrowth is not suspected. So this is a negative test. Now with a glucose test, first thing you might look at this, when we compare this to lactulose, it looks strange because we don't have this increase in gas levels in the large intestine. And that's of course because the glucose substrate has been absorbed. So as it's making its way down the small intestine, it's going to be gradually absorbed into the body, and therefore it's not going to reach the large intestine to be fermented there. Now, it does happen on some occasions that we run glucose tests. We might get a peak in the large intestine, but mostly with glucose, you won't see that. And that's not a problem, of course, that's to be expected. So if you're using glucose as a substrate, you need to be aware that it is going to look a bit different. So same here, going to check the sample normalization values. All these are normal, nothing is in red. So we know it's a good test. Looking at the boxes here, bacterial overgrowth is not suspected. So again, we've got a negative glucose breath test here. Now, here we have a lactulose test. So to go through some examples, and we can see sample normalization, no problem. So we know the test is good. And as we can see, baseline is a little bit high, and often I'm always going to ask the patient, okay, did you do all the preparation procedure correctly? Did you follow the diet the day before? You didn't brush your teeth before the test, and make sure that they followed all those rules correctly. And then if they have followed all that, great. Sometimes they say, oh no, I didn't read the instructions properly. So you need to check on that. But if this patient has followed everything correctly, then we're looking at a good test performance by the patient. Great. And we can see there's some red boxes here. Bacterial overgrowth is suspected. And that's because there's an increase in methane values, and there's an increase in combined hydrogen and methane values as well. So it's these parts per million of gas has basically reached these points here where it triggers the analysis to say, yes, there is possibly bacterial overgrowth suspected here. Now, what you need to be aware of is when you look at these tests, you need to look at things like the baseline sample, because if you get a level of gas that starts high and remains high but doesn't increase very much, remember that the analysis here is just actually calculating the increase in gas. So in cases where there's not much of an increase in gas, it may be a few parts per million for methane, it may be 10, 12 parts per million for hydrogen, but the levels have started very high, then that is something that we would still treat clinically. So don't always just look at the analysis of the data and what the what it actually says here. You need to look at the graph itself. So when we see kind of elevated and sustained elevation of the gas levels, we're typically thinking that there's a real problem there with the migrating motor complex. It's not doing its job very well, and bacteria has been able to grow all the way up into the proximal part of the small intestine. So in this case here, we have slightly more of a methane dominance in the small intestine. So in this case, you know, and often with other cases with methane, really we're looking for an ideally a level of less than 3 parts per million. So if the patient has any symptoms, especially constipation, and they have more than 3 parts per million, then we're usually going to treat them for SIBO, especially methane dominance. And then I think, yeah, cases which are harder to treat. So normally if you've got elevated baseline or certainly early elevations in the gas, which then are sustained, these sustained elevations throughout the test, usually I find that those patients or clients are going to be they're much harder to treat. You're going to have to work on that longer. You're going to have to do more work for things like the migrating motor complex, which is, you know, that kind of peristaltic type action pushing the bacteria into the large intestine. So here's a clear example here of a positive result. The test really helps you out here. Some red boxes, and then also it tells you the increase in gas going on, but remember to always just look at where's the starting point. So here, another example, just as I was saying before, we've got high and sustained baseline elevation. We're then almost higher here than we are in the large intestine. You might see that sometimes. It's not necessarily anything to be worried about. This test has been completed correctly. And this is one where it says, look, bacterial overgrowth is not suspected. And that's because there's not been any increase of gas really throughout the test. But these levels of gas are still too high. So again, here we've got a red box, and although it's not on this picture, but there's a little star here, and it's basically saying if the methane level is above 3 parts per million and the patient has symptoms, especially constipation, then you should consider, you know, treating or working with that SIBO to improve those patient IBS symptoms. So in regards to treatment, really it's gas dependent. So for hydrogen dominance, so if you have a blue line elevation, then classically what I'm going to use, or that the team's going to use, is oregano oil, neem, or berberine. So there usually are like go-to supplements that we use. And then also, of course, because we have medical doctors on the team here, we can use rifaximin as well. For methane dominance, then you want to use allicin or Alamed for sure. So we use a lot of Alamed here at the clinic. And then typically we're going to combine Alamed with one of these below. Our kind of most used is definitely oregano oil, neem, followed by neem and berberine. We often, if patients are overweight, we might try berberine because it has sort of a very mild metformin type effect. So if we can get more benefits out of certain supplements, we will use those over others. But methane dominance, you definitely want to use allicin, and the product we have in the system is called Alamed. That's really important for methane treatment. Now, there is a product called Atrantil. It's developed by a gastroenterologist in Dallas, I believe, in the US. This is not it's not a product that I use very often, but I would call it kind of one of my troubleshooting products, that if some of these standard approaches are not working, then I would go to something like Atrantil and see if that helps. But it wouldn't be necessarily a first step or stage of treatment for me, but I might go to it if things aren't working so well. And then Atrantil, I mean, again, like most products, I see in some people it can be very, very helpful, in others not so helpful. So some of these things are a bit trial and error. And then, of course, methane dominance, we have antibiotics, rifaximin, and normally for methane dominance, which is also classically, but not always associated with constipation, we're using rifaximin and metronidazole for patients that want to be treated with antibiotics. But of course, we generally prefer to use the supplements like oregano oil and allicin, etc. They usually are preferred choice over antibiotics. Now, other possible options, we have things like caprylic acid or Capril, grapefruit seed extract. You have biofilm disruption. Again, usually these are not my like first stage options. If we're not getting progress with some of the other products, then I might go to a biofilm disruptor. I might try something like Capril or grapefruit seed extract. And then there are probiotics. So of course, big question often gets asked, okay, what probiotics can help for SIBO? These are the strains from the research literature that are associated with improvement in outcomes. So look for these strains in particular if you are going to go for a probiotic option. But as I say, usually we really heavily favor the supplement option first. Other possible options, Atrantil, etc. We do use antibiotics, but it's not so often. And occasionally we'll use probiotics alongside. Now, there are different treatment strategies in regards to diet. These four maybe being some of the common options. I have used a lot of the biphasic diet in the past. Occasionally use the elemental diet. Of course, low FODMAP is used a lot by many practitioners. I would say that I've really done some swings and roundabouts with diet approaches. Sometimes I've used them a lot with clients, but at the moment, I tend not to use a lot of low FODMAP or biphasic diets with patients. Of course, there's some evidence to say that feeding the good bacteria, feeding the SIBO bacteria with there's some kind of FODMAP foods actually improves treatment outcomes. So I've moved slightly away from diet treatment strategies. I mean, of course, in Sweden, in Stockholm, most patients, I have to say, overall, compared to when I lived in London and worked with, like, you know, lawyers and bankers and worked with some of my American clients, you know, the average like nutritional like intake and strategy here is a lot higher. So I found, you know, as I've moved to Sweden and worked here, I've had to use less of these type approaches, but there's still approaches that I use. I definitely have one patient at the moment using the elemental diet, but I tend to go to these later on now. If the first treatment strategies aren't working, then we may go to adding, you know, the biphasic diet in with treatment or low FODMAP approach. And those are the two in the middle that I've had most clinical experience with. Now, once you've like treated or worked with your client or patient, and you know, they're really satisfied with the results, then we want to go into a maintenance phase. And in regards to that, we have some supplements like 5-HTP, HCl, and you have bitters. So you could use some simple things like lemon water or Swedish bitters or apple cider vinegar, just to help keep stimulating the digestive system. Probiotics as well. So this strain here, Lactobacillus reuteri DSM 17938, that's associated with helping actually maintain a small intestine that is more free of bacteria. So that's the best probiotic from a research perspective for maintenance. And of course, some patients, we use the medical option, we use Resilor, precalopride. So once, yeah, we've got to that point where either the test is negative, or, you know, ideally the test is negative and the patient is reporting no IBS type symptoms, then we're going to move into a maintenance phase. And that treatment phase, I mean, in some cases it might be, you know, many months, 6-9 months in some cases, possibly even a little bit longer if you're working with, you know, really tough chronic cases of methane dominance, of gas levels well above 100 parts per million. So some examples of cases here where we've had some good results. So this patient came to the clinic with bloating and constipation. We can see that this was more methane dominance, but also hydrogen was elevated as well. So it's really, you know, big. There's a combined result going on. Sample normalization was fine, so no problems with the test. And in this case, what I used was oregano, so 200 milligrams 3 times a day, and actually used Alamed 900 milligrams 3 times a day. So it's quite high dosing in this case. And I just basically, you know, this was a patient that didn't want to change. The protocol was very like, if you give me too many things, I'm not going to be able to do it. So I kept it very simple and just kept this patient on that for 6 months. And at that stage, we had a review. You know, again, this patient didn't have a lot of money to, you know, do repeat testing. So we just went entirely off symptoms. And at 6 months, she was 90% better at that stage and was very, very happy, you know, having had these symptoms of bloating and constipation for many years. So then we just moved her into a maintenance phase at that point. But this is what we can see, especially, you know, methane levels that are up at, you know, reaching peaks of 115. I found that generally they need to be on treatment for 6 months. But of course, if the patient's feeling a lot better, you know, almost normal functioning before that, you can take them off the treatment. And then this patient here, so IBS, bloating after meals. So we can see actually not necessarily a too bad baseline 20-40 minute test, but then really as we're getting towards 60 minutes, the increases are happening more significantly. So what we did here is did 4 weeks of oregano and berberine at these amounts, so 200 milligrams 3 times a day and 500 milligrams 3 times a day. And then after that 4 weeks, then from 4 to 12 weeks, switch the berberine out for Alamed. And this patient was a little bit overweight, was open to losing some. So I started with the berberine to see if it would help. Didn't use it for very long because I wanted to get the Alamed in, especially for these this higher methane level going on here. And basically kept her on that track for 12 weeks. And then this was the follow-up test. So it's not necessarily perfect, but where we're getting most of these reds, especially this increase in hydrogen, is coming from the transition period. So again, it might just be she has a slightly faster transit time because at this point, all her symptoms had gone. So again, if all symptoms are gone and the patient feels much better, even if there are still maybe some red boxes here, it might not look absolutely like textbook perfect. I'm not necessarily going to keep on treating the patient, any further than required. So always consider symptoms with the test results. But in this case, for this patient as well, I used a time-restricted feeding window. So basically 10 hours of eating during the day. And because basically this patient was eating, virtually snacking over the whole day, just got more movement into her day and worked on her circadian rhythm, because I believe that's really important for things like good digestive function and chronic SIBO treatment. So I'm always looking at lifestyle contributors, but of course we want to combine that usually with a treatment and hopefully get a good outcome at the end. Now, of course, if patients want to know how they're progressing, if we feel that they're not progressing as they should, then we might run a test to find out how they're doing in the middle of their treatment. It really depends. So in general summary, test preparation and completion is really important. Use lactulose unless the patient or client is allergic. That's my general advice. Suggest a good treatment based on the dominance, what the patient can do, what's affordable, and be prepared to change your strategy if it's not working. We do have some really chronic IBS cases. In the first treatment, it doesn't work. We have to change strategy, try some different things like a Trantil, or maybe some different herbal treatments, or maybe even go into antibiotics. Use repeat testing to understand how your treatment is working. So again, if symptoms aren't progressing as you think they should be, you can always run a test to find out how it's going, and just make sure things are on track. And then once the patient or client is better, make sure you move into a maintenance phase. And if things aren't moving ahead, troubleshoot as best you can. So look at things like thyroid function. If you haven't done a stool analysis, you might be missing an infection or a problem with pancreatic enzymes. Look at circadian rhythm and their diet. Of course, I'm sure most of us are on this call because we're doing those type of things. But if you're just doing straight treatment, often that's not as effective as it could be unless you're combining with these other lifestyle or tests or other systems of the body that may not be working properly. Okay, so yeah, that was kind of basic SIBO in a whirlwind 30-40 minutes. Not too bad, not too late, Anne-Catherine.
You did very well. You did very well, and lots of questions have come on the side. And I'm just going to take some of them, and some of them I'm going to comment to, and some of them I'm going to pass on to you. So a question came up on fructose intolerance testing, and we do offer that as well. I didn't remember, I haven't put down the names of who asked what questions and so on, sorry about that. But it was a question about a protocol with a practitioner who uses all 3 types of testing. But most practitioners really use the lactulose test, but the fructose test is in our system as well. So you can order that there as well. Then in the beginning, you also mentioned how you would sometimes use other tests in combination. And just FYI for you practitioners, the more tests you order in one order, you can get discount if the pack is there. So like I very often use CSAP ×2 with a SIBO test, and perhaps even an IPA or an organics. So there are some combinations that allows for a really good discount for the patient, so they don't have to pay kind of full price for all 3, because we are handling the test less when we just ship out in 3 tests in one go. So look out for that when you are ordering tests in the system. And there isn't combinations for everything. So there's some combinations, and those are the combinations that there is. Then in regards to collecting, then we had some intern students that made some video demos on how to collect and how to blow into the collection device. And that in our instructions, there is a link to that video, so the patients can look up into that. And you can also find that instruction under the SIBO test as a video. So you as a practitioner can go in and look at it. You might want to show it to your patient, or what I do, I put the link in my journal notes, because I have journal notes that my patients see. So they can see the link there and go in and see how it's done, how the collection is done. Yes, of course, other antimicrobial supplements are available. Colloidal silver was mentioned, and there's other things in Nordic VMS. I think Graham just mentions what he normally uses or uses the most or have seen most success with, but there are other things in there as well. Now, Graham, are you ready?
Yeah. Let's try.
So, migrating motor complex.
Yes.
And how do you support that? What's your protocol for supporting migrating motor complex?
Fasting needs to be as long a fast as possible. Ideally, really for chronic cases, 16 hours overnight would be best, but of course, 14, a minimum of 12 hours for that. And then really no snacking in between meals. So try and, either ideally a 2 or 3 meal strategy per day with, a good amount of time in between meals. Then, of course, we have the medical options like Resolor, but then you can use things like, ginger, and there is 5-HTP as well. Also, good sleep. Melatonin is important for basically small intestinal motility. So we see sometimes when running Dutch tests with chronic SIBO cases that they often can have low melatonin. And also walking and loading, basically loading the bones, because there's a substance released, which I can't remember off the top of my head, but if patients aren't moving and exercising, then motility in the small intestine is going to be reduced. So I would say that they're my like main ones to go to, but of course there are other products which I've dipped in and out of over time. But really for motility, I'm looking more for more impact coming from lifestyle factors, certainly, you know, medium to long term. So usually short term, maybe using some support, and then all that time working on lifestyle, especially fasting routines, and occasion, I mean, also using things like the fasting mimicking diet because of how the migrating motor complex can be damaged. So I might be using either longer water fasts or the fasting mimicking diet, especially because we want to get that autophagy and increase like stem cell process to see if we can repair it at all.
Excellent. Now, I got a little bit flabbergasted, and so did all the others, when you said you don't really use diet that much any longer.
I saw
while you answer that, I'm going to turn on the light here. So
the controversy in the chat went up a level. Yeah.
So tell us why that is.
Well, I think over the last 10 years, I've gone through, I always, used like diet very heavily, but then with emerging research that actually certain like FODMAPs or, you know, giving fibers with treatment actually can help improve outcome. So I started using more of that type of approach rather than limiting fibers, keeping them in along with treatment. So I did that, and then also found that like the biphasic diet, I mean, it is hard to stick to. It's not simple just to understand what to avoid. Like, okay, avoid gluten, or, you know, avoid. I mean, even that for some patients is very difficult. So I found I had quite a not necessarily a super high number, but patients would just not be able to do the protocol if I was asking them to take, you know, 12 capsules a day and do the biphasic diet and work on, you know, walking and sleeping. And ultimately, I don't think that FODMAPs are the problem per se. It's just that there's problems with the migrating motor complex and things that have contributed to slow motility in the small intestine. So I also get worried about long-term elimination of FODMAPs for the bacteria in the large intestine, and what are the implications there long-term. So it's not that I'm not using diet approaches, because I am, but it's just that whereas I would say before it was like my go-to, I'll get you on a low FODMAP diet to everyone. Now I've turned that around, and I'm going more in with treatment and trying to get more lifestyle factors in place very early on. And then if they're not progressing, I might move into a low FODMAP or a biphasic diet. So that's, I can't say I'm not sitting here and saying it's right and I've got it the right way around, but I change it for the different patients, and I still get a lot of, you know, good results doing this way. I would say it's improved by far the amount of patients that can actually do the plan. I've had a lot less like dropouts, or and I think that's sometimes the problem, is if you can show some improvement early on and without scaring them away by too many interventions, then they'll be with you for a longer time, and then you can have a better long-term effect. So that's just where I am. I'm not saying they're wrong, and I'm not saying don't do them. I'm just saying that's where I've come to with my like clinical treatment of SIBO. Maybe I end up going back more to diets at the start, but that's where I am right now.
I can just add where I am. So when I see the patient first time, I don't necessarily know what's wrong with them, if they have SIBO or dysbiosis or some yeast or parasites and so on. So I suggest that they collect their lab tests, and once they've collected the lab tests, that they start the low FODMAP diet, and it's gluten-free and casein-free. I do a very thorough dietary plan for them, so they understand how to change out and put in foods and so on. Because we have 3 weeks, we have a window of 3 weeks where we are waiting for the test result. We're waiting to find out what's there. And if I, in those 3 weeks, can give them some form of amelioration in their symptoms, that's what I want to do, because that's why they're there. So that's just my take on it. I've never even thrown maybe a few patients into the biphasic diet, because it is quite complicated, and someone is writing gaps as well. I haven't really worked with that one either. In some kids I've done it. But yeah, you have to kind of, sometimes the diet is worse than the symptoms if you put them on a really horrible diet.
Yeah. I mean, I have to say also, like my background is I'm not coming from like a dietitian background or nutritional therapy background. So I think it's also, obviously my approach is more in relation to my training. Like any, if you're a psychologist and looking at SIBO, then you probably think it's a psychological disorder. And if you're, a nutritionist, you probably work just with the nutrition. If you're an endocrinologist, you probably think, oh, it's thyroid related. So there's also probably some of that I've not come from like a strict like nutrition or dietitian training background.
Super. Let's there were a few questions in regards to medication, like if you use the rifaximin. Someone mentioned a protocol with neomycin 1 week, and then metronidazole for, I think, was it 1 week, and then metronidazole for 1, or was it 2 weeks? Anyway, it was written in the notes, and then rifaximin at the same time. I thought about how there's a study where they also use both rifaximin and guargum also to keep the rifaximin for a longer time in the gut. So just like with supplements, there's different protocols, and you have to kind of like try out what works best. And same, I guess, goes for prescriptive drugs.
Yeah, we don't have neomycin, or we can't use that in Sweden. So that's why I'm writing metronidazole, because that's one that we have access to and we use. And yeah, we would, for like constipation dominant, which of course is classically methane, if we're using antibiotics, then we'll typically use rifaximin and metronidazole, usually for 14 days. And often with maybe guargum in some cases.
Super. I have not heard about celery juice being a good prokinetic. Have you?
I don't, well, I've not necessarily heard of that, but it works in a similar way to sulforaphane. I think it works on the NRF2 receptor. So, I mean, celery juice, I tend to use more in patients that have inflammation, high calprotectin. So when I'm trying to get that NRF2 activation, then Brocolox and celery juice are usually products that we'll use.
Super. So then one question came up, like if a patient gets reflux on oregano or oil, what to do? I would, into that question, I would even add other, like if a patient gets symptoms to the supplements that you're giving, like what to do, kind of.
So I was just answering a question there, and Catherine. I was like,
no, it's more like if a patient is reacting to one supplement, well, then I would try with something else. Now with oregano oil, you can get the reflux, you can even get constipation on it as well. So, but you really have to see if the patient is responding well to the supplement. Otherwise, try something else.
Yeah, or I mean, sometimes just changing things like with food. If you're using oregano oil away from food, then sometimes you just move it with food, and that can help. Or yeah, you have to change it out completely for something else and see what works.
Maybe they don't produce enough stomach acid, and someone is mentioning the quality of the supplements and so on. So yeah, there's many good practitioners here who could do the talk as well. So but we're just trying to outline it and give ideas and inspiration as how we or at least how Graham is working with the SIBO test, and you're humble.
Yeah, I think it's important to say that, you know, don't have all the answers, and not, you know, it's not necessarily of the right way. There's a lot of different ways in which you can get results with the digestive system, and it's, you know, trying to find that right way for each person, and that's very difficult at times.
It is.
Yeah.
So I think we'll say thank you very much now for the entertainment and good ideas and sparring and what have you. Next time is GI Map, is that right?
Yeah, I think so. Absolutely. Yeah.
So that's taking on from this subject, of course, and that's in about a month's time. And remember, in between then we'll send out invites for a webinar on autism. So yeah, thank you everybody. How many are we? 100 left now. So well done, Graham. Do you want to say a word before we close down?
Thanks everyone for attending and contributing. So yeah, we'll see you in a few weeks' time.
4 o'clock in about a month's time. Yay.
Okay. All right. Bye.
Take care. And remember, we are recording, so we will send out the recordings and the slides and maybe something else. Find out. Bye.
Bye.